Dear students, today we are going to discuss the next glomerular disease and which is called the membranous nephropathy. In previous lectures, we have discussed the minimal change disease and focal segmental glomerulosclerosis. Today, we are going to discuss the membranous nephropathy. Membranous nephropathy is the most common cause of the nephrotic syndrome in non-diabetic Caucasians. So, in membranous nephropathy, nephrotic syndrome is very much common and it is the most common cause of the nephrotic syndrome in non-diabetic Caucasians. If we talk about the classification of the membranous nephropathy is basically classified in two types. Number one, primary, and number two, secondary. Primary membranous nephropathy is found in usually 60 to 70% of the cases, but 30 to 40% cases of the secondary membranous nephropathy are also found. So, primary membranous nephropathy, what is the primary membranous and what is the secondary membranous nephropathy? When we discuss in brief about the pathogenesis of the membranous nephropathy, we usually found there are some kind of antibody formation against the podocytes. What are the antigens which are related to the podocytes against which these antibodies are formed, which we will discuss later. But in regard of the pathogenesis, number one, the formation of the antibodies against these antigens. Number two, there may be some circulating antibodies or there may be some circulating antigens against which the antibodies are formed. So, for example, the bovine serum albumin. Bovine serum albumin is a kind of antigen which is being trapped in the glomerular capillaries and antibodies are formed against this. So, these circulating antigens are basically responsible sometime for the membranous nephropathy. Other than this, there may be antigen-antibody complex formation. And this complex formation may deposit in the glomerular capillary wall or in glomerular capillaries and may be responsible for the membranous nephropathy. But this may be the rare cause of the membranous nephropathy. So, in brief, if we discuss about the pathogenesis, number one, antibody formation against the podocyte antigens. Number two, circulating antigens which are being trapped in the glomerulus and the antibodies are formed against these antigens. And number three is the antigen-antibody complex formation which are being deposited in glomerular capillaries. Now, if we classify the membranous nephropathy may be the primary and the secondary. When we talk about the primary membranous nephropathy, it means that the most common cause that we discuss, the antibodies against the particular antigens of the podocytes, is responsible for the primary membranous nephropathy. And what are these antigens? So we are discussing the primary membranous nephropathy and we are discussing the antigens against which the antibodies are formed in membranous nephropathy, primary membranous nephropathy. So, the number one antigen is the M-type PLA2R receptor, phospholipase A2 receptor, M-type PLA2R receptor. In 80 to 90% of the cases of primary membranous nephropathy, these antigens are formed. The second antigen is thrombospondin type 1 domain containing 7A. This is the antigen thrombospondin type 1 domain containing 7A, and in 2 to 5% of the cases or 10% of the cases, these antigens are responsible for the formation of the antibody and responsible for the membranous nephropathy. The next antigen is the neutral endopeptidase. Neutral endopeptidase is also antigen against which the antibodies are formed, but these are of rare kind. Next antigen is the bovine serum albumin. Bovine serum albumin is also antigen against which the antibodies are formed, but these are also of rare type. The next antigen is the recombinant aryl sulfatase. Recombinant aryl sulfatase, against which the antibodies are formed and responsible for the membranous nephropathy. So these are particular antigens which are responsible for the membranous nephropathy. The most common is the M-type PLA2R antigen. The second is the thrombospondin type 1 domain containing 7A antigen. The third is the neutral endopeptidase antigen. The fourth is the Bowen serum albumin antigen. And number 5 is the recombinant aryl sulfate antigen. So these are the antigens which are responsible for the primary membranous nephropathy, in which the most common type is the M-type PLA2R. Now we come to the secondary membranous nephropathy. What are the causes of secondary membranous nephropathy? So we have discussed the causes of the primary membranous nephropathy. These are the antigens related to podocytes mostly. And now we are going to discuss the secondary membranous nephropathy. Secondary membranous nephropathy is basically responsible some secondary causes. For example, number 1, drugs. Drugs, the most common drugs which are responsible for the membranous nephropathy are NSAIDs, gold and mercury. These are 3 drugs which are responsible for the membranous nephropathy and the secondary cause of the membranous nephropathy. Second secondary cause of the membranous nephropathy is the autoimmune disease. Autoimmune disease like SLE, rheumatoid arthritis and Sjogren. So in secondary causes, we are discussing the secondary causes of the nephropathy, and we have discussed the number 1 drugs and number 2 the autoimmune disease. Third is the alloimmunity. What is alloimmunity? Alloimmunity basically when there is graft versus host disease or allograft rejection, then this rejection or this graft versus host disease is responsible for the membranous nephropathy. Next common cause is the malignancy. We are discussing the secondary causes, and the next common secondary cause is the malignancy. In malignancy, basically the solid organ tumors are mostly responsible for the membranous nephropathy. And what are these solid organ tumors? Like lung, GI tract, breast, uterus, etc. Beside this, the Hodgkin's disease and non-Hodgkin's lymphoma are also responsible for the membranous nephropathy. And the last secondary cause of the membranous nephropathy is the infection. When we talk about the infection, the most common cause of the secondary cause is the hepatitis B virus. So we have discussed the primary cause of the membranous nephropathy. We have discussed the secondary cause of the membranous nephropathy. Primary cause, in primary causes, most of the causes are related to the antigens against which the antibodies are formed. In secondary causes, mostly the secondary diseases or agents or drugs or immunity or infection is responsible for the secondary membranous nephropathy. Now, clinical features. How membranous nephropathy presents? Membranous nephropathy presents with nephrotic syndrome. In 80% of the cases, membranous nephropathy presents with the nephrotic syndrome. But if there is acute kidney injury, if membranous nephropathy is associated with acute kidney injury, the renal vein thrombosis may be common if albumin is less than 2.8. Suppose if there is nephrotic syndrome and there is hypoalbuminemia and the albumin is less than 2.8, then it may present with the renal vein thrombosis also. So the features of the nephrotic syndrome will be there. There may be present hypoalbuminemia, and hypoalbuminemia may lead to the renal vein thrombosis. Membranous nephropathy can also present with the chronic kidney disease or CKD after so many years. Now, how we diagnose the membranous nephropathy? Membranous nephropathy is basically the gold standard to diagnose the membranous nephropathy is the biopsy. Renal biopsy is for the diagnosis of membranous nephropathy. And what we find what we find in biopsy. So first of all, we talk about the light microscopy. What will we find in light microscopy? In light microscopy, there is thick glomerular capillary wall with spikes. When we see in light microscopy, the capillary wall will be thick and there will be the spikes. When we see immunofluorescence, in immunofluorescence there is found usually the deposition of the IgG and C3. So we have done the biopsy, we are seeing in the light microscopy. In light microscopy, we usually see the thick glomerular capillary walls with formation of the spikes is the characteristic of membranous nephropathy. But in immunofluorescence, we usually see the deposition of the IgG and C3. In electron microscopy, we usually see the subepithelial deposits. In electron microscopy, we see the subepithelial deposits with food process effacement. So, renal biopsy. In renal biopsy, if we see the light microscopy, in light microscopy, we see the thick glomerular capillary wall with spikes. In immunofluorescence, we see the deposition of the IgG and C3. In electron microscopy, we see the subepithelial deposits with food process effacement. So, this is the diagnosis which we usually make by doing the biopsy. Now, how are we supposed to differentiate the primary membranous nephropathy with secondary membranous nephropathy on the basis of the findings of the biopsy? Suppose, if someone says, how will we differentiate whether the membranous nephropathy is because of the primary causes or membranous nephropathy is because of the secondary causes? How will we differentiate? So to differentiate membranous nephropathy on the basis of the biopsy, we are supposed to see the light microscopy first. In light microscopy, as we discussed, there is thick glomerular capillary wall with spike formation. So this is the characteristic of the primary membranous nephropathy. But if the secondary membranous nephropathy is because of the malignancy, so there may be the leukocyte infiltration. And this leukocyte infiltration is suggestive of the secondary cause of the membranous nephropathy, most likely the tumors. Number one. Number two, the type of IgG. If we talk about the primary membranous nephropathy, the most common cause of the most common deposition in primary membranous nephropathy is the IgG4 deposition. But in secondary membranous nephropathy, there may be the deposition of the IgG1, IgG2. There may be the deposition of the IgG1, IgG2 and IgG3. If there is the deposition of the IgG1 and IgG3, so it may be the secondary, and secondary may be because of the lupus. Got it? If the deposition is of IgG1 and IgG3, so it may be because of the lupus. But if there is the deposition of the IgG2, so it may be because of the tumors. So in secondary causes, there are usually not deposition of the IgG4. In primary membranous nephropathy, mostly the deposition of the IgG4 is found. And in secondary membranous nephropathy, the deposition of IgG1, IgG2 and IgG3 is found. And especially if there is the deposition of IgG1 and IgG3, it is because of the lupus. And if there is the deposition of the IgG2, probably this may be because of the tumors. Now, what other thing we can see to differentiate the primary membranous nephropathy with secondary membranous nephropathy, and on the basis of the biopsy findings, and that is the deposition of the or IgG formation against the tubular basement membrane. If there is IgG formation against the tubular basement membrane, so they may be because of the secondary membranous nephropathy. In primary membranous nephropathy, there will be no IgG against the tubular basement membrane. What else The deposition of the C1q. The deposition of the C1q. In primary membranous nephropathy, there will be no deposition of the C1q. But in secondary membranous nephropathy, there will be the deposition of the C1q because of the lupus. So this is the differentiation of primary membranous nephropathy on the basis of C1q to the secondary membranous nephropathy. Next may be the electron dense deposits. Electron dense deposits subepithelial or intramembranous. Subepithelial or intramembranous electron dense deposit on electron microscopy findings may be positive in primary membranous nephropathy, but not in secondary. So this is another difference. Another difference may be the endothelial tuberoreticular formation. Endothelial tuberoreticular formation or endothelial tuberoreticular inclusions may be negative in primary membranous nephropathy but will be positive in secondary membranous nephropathy. So these are the differences, or these are the findings which we see to differentiate the primary membranous nephropathy from secondary membranous nephropathy. Now, how do we evaluate? What workup we do to find out the causes of membranous nephropathy? Number one, first of all, we are supposed to see the antigens, and the most common test we do is the anti-PLA2R antibodies. Anti-PLA2R antibodies usually done to rule out the primary membranous nephropathy, which is very much common, and most of the labs usually perform this test. The second is thrombospondin. As we discussed, thrombospondin type 1 domain containing 7A, but most of the centers do not do this test, so we usually perform this test on particular centers only. But in 2 to 5% of the cases, these are common. This is the cause of the membranous nephropathy. That's why we are supposed to perform this also. But others are rare antigens. We usually do not perform this test. What other evaluation we can do? We are supposed to screen for the renal vein thrombosis. We are supposed to screen for the autoimmune diseases. We are supposed to screen the secondary causes. And we are supposed to screen for the tumors. So when we do the evaluation of the disease, we usually do the antigen test. We usually check the antigens by doing the antibodies against these particular antigens. So if we are supposed to do the PLA2R antigens, so we are supposed to do the anti-PLA2R test. And if we are supposed to do the autoimmune profile, then we are supposed to check the secondary causes, the autoimmune diseases. And if we are supposed to rule out the renal vein thrombosis, then we are supposed to do the Doppler studies, etc. But we are supposed to evaluate, or we are supposed to check the other secondary causes which are responsible, like hepatitis B virus, like other causes like the cause like drugs, NSAIDs, gold, which we have discussed before. And finally, we are also supposed to screen the tumors. Screening for the tumors. Suppose a patient is of 50 to 75 years of the age, then we are supposed to rule out the colorectal carcinoma. If a patient is of 50 to 75 years age, we are supposed to rule out the breast carcinoma. If a patient is of 21 to 65 years of age, or 20 to 60 years of the age, we are supposed to rule out the cervical carcinoma. If the patient is of 35 to 80 years of age, then we are supposed to rule out the lung carcinoma. So these we are supposed to go for the screening of the tumors to rule out the secondary as well as primary causes of the membranous nephropathy. So we have discussed all this. We have discussed the causes, we have discussed the classification of the membranous nephropathy, clinical feature, diagnosis, the differentiation on the basis of the biopsy, and we have discussed the evaluation, how we evaluate the causes of the membranous nephropathy. Now we come to the treatment. When we discuss about the treatment, so first of all, if there is cause is the secondary, then we are supposed to treat the secondary cause. But if the cause is primary, then we are supposed to go in a step 1 to step 2 pattern, or we are supposed to treat the patient accordingly, individual to individual. Now what is this treatment? So in regard of the treatment of the membranous nephropathy, first regimen, we talk about the first regimen, and that is the alternating cyclophosphamide and glucocorticoid. Alternating cyclophosphamide and glucocorticoid. What is the meaning of alternating? Alternating means we are supposed to give the cyclophosphamide and glucocorticoid on alternate basis. For example, for first 3 and 5th month, we are supposed to give the glucocorticoid. And for the 2nd, 4th and 6th month, we are supposed to give the cyclophosphamide. This is also called the modified Ponticelli. So in alternating cyclophosphamide and glucocorticoid regime, what we do, we usually give the glucocorticoids on 1st, 3rd and 5th month. And each month, for first 3 days, we are supposed to give the methylprednisolone 1 gram. Methylprednisolone 1 gram for the first 3 days, and the rest of the days we are supposed to give the glucocorticoids. On 2nd, 4th and 6th months, the total duration of the therapy will be the 6 months of this alternating cyclophosphamide and glucocorticoid. But for cyclophosphamide, we usually continue the cyclophosphamide for the 12 months. But we stop the glucocorticoid after 6 months. But in this 6-month therapy, for the 1st, 3rd and 5th month, we are supposed to give the glucocorticoids. And for the 2nd, 4th and 6th months, we are supposed to give the cyclophosphamide. And every first 3 days of this first 3 and 5th month of the glucocorticoids, we are supposed to give the methylprednisolone 1 gram once a day. So what will be the dose of the glucocorticoid? The dose of the glucocorticoid is 0.5 milligram per kilogram body weight, and the dose of the cyclophosphamide will be 2 to 2.5 milligram per kilogram body weight. So this is the regimen which we call alternating glucocorticoid and cyclophosphamide. What is the other regimen? Other regimen is continuous cyclophosphamide and glucocorticoid. For example, we are not supposed to give on an alternate basis. We are supposed to give glucocorticoid and cyclophosphamide continuously for 6 months glucocorticoids. And this therapy is usually give continuously and not alternate basis. The dose of the glucocorticoid will be the same, 0.5 milligram per kilogram body weight, and the dose of the cyclophosphamide will be the same, 2 to 2.5 milligram per kilogram body weight. Glucocorticoid for 6 months only, and the cyclophosphamide for 1 year. So this is the continuous corticosteroids and cyclophosphamide regime. What is the third regimen? The third regimen is calcineurin inhibitors. We can give the calcineurin inhibitors. Calcineurin inhibitors are basically two. The number 1 cyclosporine and number 2 tacrolimus. The cyclosporine we usually give for the 12 to 8 months, and the dose of the cyclosporine is 3 to 5 milligram per kilogram body weight. With this cyclosporine, we are also supposed to give the prednisolone 5 to 10 milligram per day. So we are talking about the second regime, and the second regime is calcineurin inhibitors. Calcineurin inhibitors are usually two. Number 1 cyclosporine and number 2 tacrolimus. The duration of the therapy is usually 12 to 18 months. And when we talk about the cyclosporine, the dose of the cyclosporine is 3 to 5 milligram per kilogram body weight. And the trough level, we usually keep 150 to 200 in case of the cyclosporin. And with this cyclosporin, we are also supposed to give the prednisolone daily 5 to 10 milligram. Next calcineurin inhibitor is the tacrolimus. And the dose of the tacrolimus is 0.05 to 0.75 milligram per kilogram body weight, and the duration of the therapy is the same, 12 to 18 months. And the trough level, we usually keep of the tacrolimus 5 to 10. We are supposed to keep the trough level 5 to 8 or 10. Depends on the response or remission. Now, beside this, what is the other treatment, other regime we can give? We can give the rituximab. Rituximab, we can give either on the weekly basis, or we can give 2 doses of the rituximab with the difference of the 2 weeks. If we give the 2 doses of the rituximab, we give usually 1 gram. So, and rituximab may be repeated after 6 months. So, this is the treatment of the primary membranous nephropathy or membranous nephropathy. And now we discuss about the prognosis. What is the prognosis of membranous nephropathy? 1/3 of the patient usually get the spontaneous remission. 1/3 of the patient usually get spontaneous remission in 6 to 9 months. But if the proteinuria is subnephrotic, most of the patient get spontaneous remission. If there is complete or partial remission, so 10-year survival of the kidney is predicted. 10-year kidney survival is predicted if there is complete or partial remission. Suppose we have given the treatment and now there is complete remission or partial remission, then we can predict that the kidney may survive for the 10 years. If 50% have persistent nephrotic syndrome, for example, you have given the treatment, but 50% of the patients have persistent nephrotic syndrome, they are not responding, then 30 to 40% of the patient progress to end-stage renal disease. 30 to 40% of the patient progress to end-stage renal disease. If proteinuria is more than 8 gram, then prognosis is not good. Besides this, by investigating the anti-PLA2R antibodies titers, we can predict the prognosis. And anti-PLA2R antibodies are also predicts or also tell about the treatment, whether the patient is going in remission or not. So this is about the prognosis. What is the prognosis? 1/3 of the patient get spontaneous remission if there is subnephrotic range proteinuria. If subnephrotic range proteinuria, 1/3 of the patient go in spontaneous remission. If you have treated the patient and there is complete or partial remission, then 10-year survival of the kidney is predicted. 10-year survival. Next, if 50% of the patient have persistent nephrotic syndrome after giving the treatment, the 50% have persistent nephrotic syndrome, 30 to 40% may progress to end-stage renal disease. And if there is proteinuria, more than 8 gram proteinuria, then they have bad prognosis. So this is about the prognosis of the membranous nephropathy. Now what about the transplant? In 40 to 50% of the patients of the membranous nephropathy, recurrence occurs. There may be the recurrence. And what is the treatment of there is recurrence? The treatment is the rituximab. Rituximab is the treatment of membranous nephropathy if there is recurrence. So, we have completed the membranous nephropathy in brief, and we have completed, beside the membranous nephropathy, other causes of the nephrotic syndrome or the other glomerular diseases which we call the minimal change disease and FSGS. In next lecture, we are supposed to discuss the IgA nephropathy. We will discuss the IgA nephropathy. So, thank you.